Good morning. On behalf of Forum of Opthal Teachers of India, I welcome all of you in this particular 40 session. You all know about Forum of Opthal Teachers of India. It is the only platform in India which is for the ophthalmology teachers, by the ophthalmology teachers, and above all, for the ophthalmology teachers. Just like for the people, of the people, by the people, it is all concentrated by the opthal teachers of India, who are the main backbone and guiding force of Indian ophthalmology to prepare opthal generation next. You all know that for the last 8 years, we are working together throughout India to provide some inputs earlier to Indian Medical Council and right now the National Medical Council on the ideal ways of teaching and training program in ophthalmology, both undergraduate and postgraduate students, whether MS, MD, diploma, DNB, anything in ophthalmology. Very recently, in the second week of January 2025, we had finished our 8th National Annual Assembly of Forum of Opthal Teachers of India at PGI Chandigarh. Right now, Professor Surinder Singh Pandav, the head of the Department of Ophthalmology, PGI Chandigarh, is the president of Forum of Opthal Teachers of India. In that particular meeting, we had a day-long national symposium on the ideal curriculum for UG and PG education in ophthalmology. And we had prepared some recommendations and guidelines. And we have sent those recommendations to National Medical Council for their kind consideration of acceptance after necessary addition and alteration. Today, in this particular session, we will again refresh those particular recommendations, and we also like to make some new addition and alteration from these beautiful teachers of ophthalmology of India who are present here. Now, may I now request Professor Surinder Singh Pandav, the president of Forum of Opthal Teachers of India, to come over the dais and to take the chair as the convener of this session. Along with those, I'd like to request the President Emeritus of Forum of Opthal Teachers of India, who are kind enough to be present, to take the chair, and also the Vice President of Forum of Opthal Teachers of India, who is also present, to take the chair of this particular session. May I now request Padma Shri Professor Jagatram sir to come over the dais. He is one of the Emeritus President lifelong. Professor Lolit Nepalia sir, yet to come. Yes. Professor Satyaprakash Singh from Allahabad. Professor Jivan Singh Titial. No. Then Professor Kavita Bhatnagar Madam, HOD Ophthalmology, AIMS Jodhpur, who is now the Vice President, to come over the dais and to take the chair. Professor Subhas Dadia sir, who is now the Director Professor of Guru Nanak Eye Care Center and Maulana Azad Medical College to take the chair of the moderator. Now I would like to hand over the mic to Professor Surinder Singh Panda to go over the proceedings.
Thank you, Dr. Samantha, and good morning, everybody. It's a great pleasure to be here this morning among all the ophthalmologists, of the teachers in ophthalmology all over India. I think this is a great forum because um, we do talk about the curriculum and PG teaching, but I think there's no place where teachers can discuss among themselves, how do we go about implementing, first how to develop those curriculum, how to fine-tune them, and how to implement it finally in the ground, because the ground realities may be very different than in different places, because there's a lot of, regional variations are there. So I think we need to kind of know these problems and also have some solutions for ourselves as well as for our students. So this forum becomes very important, and I think Dr. Samantha has taken a great lead, and congratulations to him to create this forum. And a special welcome to Dr. Samantha for this meeting, and thanks for organizing this also. And then with these remarks, I'll hand over to the moderator, Dr. Suhas Dadia. So please, call the speakers. Yeah.
संजीव मित्तल इंट्रोडक्शन मेरा नहीं है
Very good morning to one and all. Very good morning to one and all. Now I request Dr. Sanjeev Mittal sir to briefly introduce the topic.
Good morning, everyone. Our experts on the dais and other experts in front of the dais. The topic curriculum. We are going to discuss today briefly the curriculum for undergraduates, MBBS, and for postgraduates. Why do we need actually to relook into this curriculum and to just express to everyone and give our deliberations? We know that we are around 700 medical colleges, and there are DNB courses also across. So over about 1 lakh of postgraduate seats are there, and almost 1 lakh of MBBS seats, and postgraduate seats are more than 50,000. So actually what happens, when we are addressing here today, we are focusing two issues, MBBS and postgraduates both. And NMC recently in 2024 September has revised the CBME based curriculum, and basically there's a lot of things to our faculty as well, what we have been teaching, what is wrong with that. So it's basically the NMC's plan is basically to make it uniform. We are not sure whether all medical colleges, all teachers are teaching in the same way with full passion, and are they covering everything, because some colleges may lack faculty. There are some places where students are more. So we would be actually looking for MBBS based part, and then postgraduate trainings. The aim is we want to make ophthalmologists who after passing should not look directly again to go in for a fellowship or to some senior residency, because I could not get a surgical exposure, or I was just exposed to cataract only, other things are not been taught to me. So with this all, we would be actually basically giving our deliberations, and we request actually everyone present here, that we should actually propagate to our colleagues in our departments, other institutions, to join this forum, so that actually we can have some deliberation and make this a noble profession. Because there is a shift towards money, private practice. But we as a teachers also should not feel let down actually. So we should also actually have a feeling that when we are teaching the students, those are the students, if we are really connected with them, when they express their gratitude, that gives a real pleasure to us, not the money actually. And most happy moments would, I think, several of the teachers would have realized when someday, like when you taught in MBBS student and you meet her or him somewhere in a conference and he or she touches your feet or just express, sir, I am in ophthalmology because of you, you taught so well. So that's a great reward money cannot give us. Thank you very much. So Dr. Dadia will take care of again. Thank you.
हाँ जी सर बुलाओ ना नहीं नेक्स्ट को बुला लो डॉक्टर पारुल so next speaker is Dr. Parul Chawla Gupta and she will briefly discuss the recommendations. Dr. Parul.
May I request Professor Pandov sir to introduce Dr. Parul?
I think Dr. Parul is associate additional professor now at PGI at our institution, the Advanced Eye Center, PGI Chandigarh. I think she is a wonderful clinician, teacher, and also a great researcher actually. And not only that, she's very much community oriented. I think she has probably organized the maximum number of camps for us in PGI, because PGI is being mostly a research institution. Those public duties sometimes are kind of they are not in our mind, but I think she's the one person to whom we go to when we have to organize some public function or that kind of thing. So I think she's doing a wonderful job for us. Thank you.
Thank you so much, sir, for your kind words. Good morning, everyone, and all respected teachers on the dais. Today I'll be reciting the recommendations. So the report of the National Symposium at 8th National Assembly of 40 on 12th January 2025, which was conducted in Chandigarh, PGI Chandigarh. The National Symposium was held on 12th January 2025 with the goal to discuss improvisation needed in teaching methods to improve PG teaching. There were 6 speakers, all were senior, experienced and renowned teachers. The symposium started with the keynote address by Professor J.S. Tetyal, former Chief, RP Center, AIMS. He talked about the future directions for the PG course. He suggested course can be divided in 6 segments. First segment is proper orientation in the department for 3 to 6 months to understand working pattern in the department. Second segment is basic classes with special focus on optics and retinoscopy, which is a must know for every PG. Third segment is start workup of a patient with history taking, a very important step of an examination. One checklist for history taking can be prepared to avoid missing even a single point. Orientation classes should be taken by faculties rather than SRs for torchlight examinations. PGs should be explained about how to deal with the patient, importance of a good attire or well dress up, proper accurate documentation of the case in the form of colored label diagrams, check for logbooks at regular intervals to check the progress of a student. Fourth segment was hands-on training in dry labs as well as wet labs before actually starting surgery on a patient. Simulators in dry lab give good exposure to steps of the surgery. In wet labs, surgical steps practice can be done on goat's eye. Once they master the steps in labs, they can assist seniors to get acquainted to OT and then start actual surgery on a patient step by step under observation. They should keep recordings of all the surgical cases to get reflections of the surgery and to improve it in future. Fifth segment is academic involvement, guidance for symposium preparation and presentation by faculties. We should motivate them to participate in national and international conferences. Thesis must be of high standard to get it published. And if possible, take help of the research grant for the thesis. Sixth segment, practice for preparation of a good performance in examinations, and that can be conducted every 3 months in the form of practice like OSCE, paper writing, grand viva and refraction. For discussions, they can form a group amongst colleagues for group discussion with peer mentorship for guidance. At this stage before exam, future career orientation sessions can also be done. Second speaker was Professor Anita Panda, who talked about the role of professors in medical education. There are many changes that are evolving in education like telehealth, e-learning, in curriculum development, clinical practice and integrated education. Workshops can be conducted for the teachers to get involved in this evolving education system. Third speaker was Dr. Tarun Panda, who discussed newer modalities in teaching and training. He suggested integration of technology may be online in live surgeries, wet lab, focus on research and subspecialty training. There are many challenges in integrated teaching, interdepartmental discussions and use of teleophthalmology, remote learning, mini clinical evaluations. Special focus is needed on public health and community ophthalmology. Innovation challenges can be overcome with collaboration with engineers. To get global exposure, exchange programs can be arranged and mentorship programs can be arranged for personalized learning. Fourth speaker was Dr. Guru Prasad, who discussed his own method of teaching. Aim of teaching is to make students do and learn. Teachers must have patience, empathy, and follow ethics. We cannot forget our orthodox teaching methods. They are the best for history taking and examination. It is very important to master torchlight examination, RAPD testing, refraction before learning subspecialty equipment. They must fill logbooks, learn video editing, and wet lab training to understand and master the procedures fast. BLS, basic life support, and advanced life support training should be given to all. Community work in outreach programs can be made mandatory to all. It is very important to check physical and mental health of the PGs before admission. Fifth speaker was Dr. Raman Rao, who talked about OSCE for undergraduates and postgraduates. OSCE must be based on competency, knowledge, and skills. For undergraduates, there should be 5 stations with 5 marks each, and for PGs, 5 stations with ocular histopathology, imaging modalities, visual fields, communication skills, and refraction should be there. It should be a summative assessment. Sixth speaker was Dr. B.K. Gupta, who talked about newer modalities of teaching, learning methods, innovative interactive teaching methods like SDL, making lectures interesting by flipped classrooms, games in between lectures, group discussions, role play, sandwich technique, and quiz should be done. Student feedback plays a major role to improve the teacher interaction. Adopt mobile ophthalmoscopy, video slit lamp imaging system to learn surgical steps. Virtual simulators are the best. Seventh and the last speaker was Professor Bhavna Sharma. She discussed training is not enough. Assessment leads the way forward. She mentioned lacuna in competency-based approach. It is not exactly followed. We need to focus more on competency, attitude, and communication skills. 360-degree assessment is essential in diagnosis, surgical procedures, and academic activities. Assessment should be regular, ongoing to assess knowledge and difficult domains. They must know how to take written consent, do proper counseling, and must be available on call for emergency. Milestones and assessment based on patient care, system-based learning as Ayushman system, practice-based learning with mentor and communication skills should be followed. Thank you so much.
Thank you. I think there was a lot of discussion in the last meeting, and I think the experts they have actually recommended what is need to be done. So this is quite kind of in line with what the National Medical Commission actually also recommends. And but the issues are that when at the implementation stage, sometimes we falter out for various reasons actually. And those reasons are common to some of them are common, some of them are actually unique to different different institutions. So basically, we need to see how we can standardize the implementation part also across the nations. Yeah, thank you. Dr. Dalia.
Thank you, Dr. Parul, and thank you, sir.
Thank you, sir.
Now I invite Professor Arvind Tenagi, and Professor Samantha will introduce him.
Professor Arvind Tenagi is in teaching profession for more than 30 years. He is the professor of ophthalmology at Belgavi Medical College in Karnataka, Belgaum. Though it's a private medical college, but it is a part of a big university, KEM University in Belgavi, Karnataka. So, and Professor Arvind is a dedicated teacher with many postgraduate students and around 250 undergraduate students under their supervision. So let's have a hear to Professor Tenagi.
Good morning, respected experts on the dais and the delegates. At the outset, I would like to thank Professor Samantha and all the office bearers of 40 for giving me this opportunity to speak on the standard curriculum which has been practiced now. It's an overview of curriculum which is practiced in all the medical colleges, although it is not uniform in all the medical colleges. The motto of 40 is to make it uniform, and I would just like to give a brief overlay of this curriculum which is there right now practicing. The purpose of UG education is to create doctors who would provide high quality healthcare and advance the cause of science through research and training. The purpose of this program is to standardize ophthalmology teaching at undergraduate level throughout the country so that it will benefit in achieving uniformity in undergraduate teaching. At the end of the training in ophthalmology, a MBBS graduate shall be able to recognize common eye ailments and treat them effectively in the community. He should be able to treat common eye ailments and refer them cases timely. Competencies like knowledge of common eye problems in the community, recognize and diagnose, manage common eye problems and identify indications for the referral, ability to recognize visual impairment and blindness in the community and implement national programs as applicable in the primary care settings. Coming to the broad subject specific objectives like knowledge, common problems affecting the eye, principles of management of major ophthalmic emergencies, magnitude of blindness in India and national program for control of blindness and its implementation at the various levels, role of primary healthcare center in organization of eye camps, integration of the national programs and other national health programs and the eye bank organizations. Coming to the skills, to elicit history of pertinent to the general health and ocular status, assist in diagnostic procedures, diagnose and treat the common problems affecting the eye, provide first aid in major ophthalmic emergencies, assist to recognize common eye surveys for visual checkup, and use effective means of communication with the public and individual to motivate for surgery in cataract and for eye donation. Coming to the ATCOM, attitude and communication skills, the communicate effectively with the patients, their families, and the public at large, communicate effectively with the peers and the teachers, demonstrate the ability to work effectively with the peers in a team, and demonstrate professional attributes of punctuality, accountability, and respect for teachers and the peers, and appreciate the issues of equity and social accountability while undergoing all clinical encounters. The teaching should be aligned and integrated horizontally and vertically in order to allow the student to understand the structural basis of ophthalmic problems, their management, and correlation with the function, rehabilitation, and the quality of life. This is the course content, the teaching learning methods, and the time allotted. This is a brief table depicting the teaching hours regarding the small group learning, self-directed learning, and clinical postings, which have been in 7 weeks in the first, second, third, first, and third, second, contributing totally to 7 weeks of the teaching program in the clinicals. Coming to the psychomotor domain, the clinical examination methods, that is history taking, case sheet writing, visual acuity testing, estimation of refraction, anterior segment examination, posterior segment examination, and other diagnostic tests like tonometry, visual field examination, and the starred one, which are to be done under the observation. They are not doing directly, but they are doing under observation. So these are all the psychomotor skills. And coming to the curriculum, this is the basic, the outlay of the curriculum, where the topics, the lectures, and the small group learning and the self-directed learning, they are been given. The basic sciences, disease of the eye, consisting of all the clinical ophthalmology, the total duration amounting to 110 hours. This is the practical training, that is in the third first, they have 3 weeks of this thing, 18 hours duration, that is 54 hours totally. And in second, in MBBS phase 3 part 2, that is clinical posting 2, they have 4 weeks, that is 24, that is 72 hours, and totally 126 hours of clinical training will be there. This is the internal and the formative assessment for the theory. This is the practicals, formative assessment, the continuous internal assessment using the logbook, and this is the university examination pattern, which consists of 100 marks. This is the practical examination, which consists of clinical 80 and Viva OC 20 marks, totally 100, contribute 200 marks. This is regarding the UG curriculum. Then coming to the curriculum of competency-based postgraduate programs for MS in ophthalmology. The purpose of PG education is to create specialists who would provide high-quality healthcare and advance the cause of science through research and training. The purpose of this program is to standardize ophthalmology teaching at postgraduate level throughout the country so that it will benefit in achieving uniformity in postgraduate and undergraduate teaching, as well as result in creating competent ophthalmic surgeons with appropriate expertise. The goals being practice efficiently and effectively, backed by scientific knowledge and skill base with a sufficient understanding of basic sciences, recent advances, and clinical applications related especially to able to integrate this knowledge into clinical practice, practice evidence-based medicine, exercise empathy and caring attitude and maintain high ethical standards, and practice his specialty ethically, keeping in mind the requirement of the patient, community, and people at large. Plan and advise measures for the promotive, preventive, and curative rehabilitative aspects of health, disease, and ophthalmology. Should be able to demonstrate his cognitive skills in the field of ophthalmology and play the assigned role in implementation of national programs for control of blindness. Continue to evince keen interest in continuing education in the specialty, irrespective of whether he or she is in teaching institution or is into practicing surgeon. Demonstrate competence in basic concepts of research methodology and writing thesis and research papers, and be a motivated teacher, defined as specialist keen to share his or her knowledge and skills with a colleague or junior or any learner. Coming to the objectives, like it is divided into knowledge, skills, and human values, ethical practice, and communication abilities. As the knowledge, at the completion of the course, the candidate should demonstrate sound knowledge of clinical manifestations of common ophthalmic diseases, including emergency situations and investigative procedures to confirm the diagnosis. Demonstrate the comprehensive knowledge of various modes of treatment, both medical and surgical. Coming to the skills, on the completion of the course, the candidate shall be able to offer to the community the current quality of standard of care in the ophthalmic diagnosis, as well as therapeutics, medical or surgical, in most of the common and easily managed situations at the district or secondary level healthcare services. He should be able to plan the educational programs for the health professionals and be familiar with modern methods of teaching and evaluation. Apply research and epidemiological methods during his or her practice. The candidate shall be able to present or publish work done by him or her. Coming to the human values, ethical practice, and communication abilities, adopt ethical principles in all aspects of the practice, professional honesty and integrity to be fostered, care is to be delivered irrespective of the social status, caste, creed, religion of the patient. Develop communication skills, in particular the skill to explain the various options available in the management and to obtain true informed consent from the patient, provide leadership and get the best out of the team in a congenial working atmosphere. The basic practices for the postgraduate before initiation of the course is good clinical practice. A postgraduate should develop good clinical practices, which is essential for training for clinical research that involve the participants, like basic life support and advanced cardiac life supports should have, they should be certified so that it will be useful in the emergencies. Then all postgraduates should undergo the NPTEL and BCBR course before they take the exams. At the end of the course, the student should have acquired knowledge in the following: that is the cognitive domain, that is the clinical ophthalmology and refraction, ophthalmic super specialties like neuro-ophthalmology, strabismology, retina, vitreous, glaucoma, etc., and community ophthalmology, research methodologies. And the affective domain, the PG should be able to learn all the affective domains so that he can be empathetic towards the patients and to the community. And the psychomotor domain, patient should be able to learn all minor surgical procedures and which are must know and perform independently, and also the major surgical procedures which should be trained under guidance and by a mentor. Coming to the syllabus of the PG course, the theory has the basic sciences, the like your physiology of the eye, anatomy, and embryology, etc., and the optics, the detailed optics, which is very important, the clinical ophthalmology, and the essential clinical skills like instrumentation and handling them, and refraction, slit lamp examination, direct ophthalmoscopy, indirect ophthalmoscopy, OCTs, evaluation of dry eye, contact lens and low vision aids management, etc. And coming to the research methodologies, the essential research skills like record keeping, basic statistical knowledge, and presentation of the papers, etc., they have to be practiced by the candidate. Coming to the teaching and learning methods, they've devised group discussions, clinical case discussion, seminars, journal clubs, rotation of specialty clinics in the form of glaucoma, retina, neuro-ophthalmology, and district residency program where they'll be posted for 3 months to the nearby district hospitals to serve the needy and the community. This is the scheme of examinations of this thing. Total theory papers 400 marks, continuing of 400 marks, and the practical 300 marks, and was 100, and total 400, and total 800 with the marks. And coming to the dissertation, which is a part of your partial fulfillment of the examinations, one should do the dissertation or thesis evaluation completely. Thank you so much.
Upcoming speakers. Is it?
Yeah, does Sandeep, yes.
I think it was excellent keynote address, and usually in the keynote address there is no more discussion required.
Okay.
Next speaker is Professor A. Suresh Raman Rao, and Professor Samanta will introduce him.
Professor A. Suresh Raman Rao was the part of the faculty of the renowned Sarojini Devi Eye Hospital, Hyderabad. Right now, he is heading the Department of Ophthalmology of a non-government medical college in Hyderabad. We welcome Dr. Suresh Raman Rao.
Thank you, sir. Good morning to everyone, respected professors on the dais, in the audience. It's nice to be in Delhi and to be invited to speak at the AIOS2025 at Delhi. And the theme of this is for the Forum of Ophthalmic Teachers of India, is the recommended modalities on the ongoing UG and PG curriculum of ophthalmology on an NMC, which was adopted at the 48th National Assembly at Chandigarh. So I'm Dr. Suresh Raman Rao, Professor HOD Ophthalmology in a private college now, after retirement from government, from Sarojini Hospital. So I'll be speaking mainly on the OSCE training and the assessment and my recent experiences, especially in the last 2-3 months only after attending the 40 at Chandigarh. So just a brief, just 1-2 lines on this. What's the National Medical Council Commission? It was established on 25th September 2020, replacing the MCI. So that's the date. And competency-based medical education was introduced on August 1st, 2019, and to empower the undergraduate and the postgraduate students with necessary competencies, that is knowledge, skills, and attitude for doing their professional duties. And OSCE is an important part of CBME. So OSCE in ophthalmology is a part of the, and has got standardized assessment format which tests the medical students' competencies in an objective, reliable, and unbiased way. And what is the competency-based medical postgraduate training for MS ophthalmology admitted from the 2021 batch? That is, these students gave the exams in 24 and 25, recently concluded. So the PGs, they were, besides the clinical cases, they had to be aware of fundus photography, fluorescein angiography. This is all from the guidelines, automated perimetry, radiological test, ERG, EOG, histopathology, and other diagnostic charts, just mentioned as other diagnostic charts. And how do we assess them finally? It is a formative and a summative assessment. And the examiners should have the criteria. We should see the students' knowledge, clinical skills, communication skills, professionalism, and emphasize on ADCOM, that is attitude, ethics, and communication, as mentioned by the previous speakers before me. And again, just the last part of the summary. Postgraduate Medical Education Regulations 2023 came into force from 29th December 2023, and it's, in short, it's known as PGMER 23. And now I come back to the examination pattern. So summative assessment, the universities have a role, and it is under the medical institutions to conduct the exams on the successful completion of the PG program. So I'm just telling you, over the last 3 months, I'm in Telangana, so I come under KNR UHS, and in Telangana. So this was the format given to me for my college, and they asked me, you can have a small modification. You can have a small modification, it's mentioned there somewhere. So this format was given to me. I had to modify it now. So when I modified it in February 2025, just 2 months back, I made a worksheet with distribution of marks and duration also. And I had full permission from my management. So I'm not talking of the long case, which I kept for 40 minutes, and short cases, 2 short cases for 40 minutes. But what I'm talking about is the OSCE method. So OSCE, it was for 30 minutes. I made it for 30 minutes. There were 6 stations. I could not change the stations. There were 6 stations. You can see there. And the afternoon session, I had fundus and refraction. For again, in some colleges they didn't mention what was the afternoon session. So I had made it 2 fundus cases, 1 refraction, and the total you see, I made it 40 minutes, 40 minutes, 30 minutes, and 40 minutes came to 150 minutes, 2.5 hours. So that's how I conducted the exams in Shahdan, over 2.5 hours, and this was approved by my management. So I won't talk about the clinical was 1 long case, 100 marks, and 2 short cases, 60 marks each. And this was by the university. I cannot change these things. And even the OSCE was mentioned for 60 marks. I could not change it. So I divided this into 6 stations. As per the NMC, 5 stations were histopathology, X-rays, ophthalmic ultrasound, visual fields, and other ophthalmic diagnostic charts. And the other thing is mentioned as blank. So I kept it as logbook here. I had to convince my management the logbook is required because of the history of the previous university. And of course, thesis is 20 marks. And the afternoon session is oral viva, 2 fundus cases, 1 refraction case, and viva includes instruments, drugs, community ophthalmology. In this, you can see the lenses are missing. So the OSCE stations, I'll stick to OSCE stations. So I made it 5, instead of 5, I made it 6 stations because I was given 60 marks. And each station, I made 2 or more charts, which was nicely given to me by my management. They made it, they took color photographs and they laminated and gave it to me. So I made it, so each 10 marks, so 5 questions. I made it objective, 5 questions, 2 marks each. And you can see the first was OSCE was histopathology, as per the NMC guidelines. Second was X-ray, CD and MRI. And third was B-scan, OCT. And the student had to pick up any one from this. And the 4th station was visual fields, glaucoma, neurological fields. 5th station was other diagnostic charts, in which I put Octa, I put FFA, and I put HES charts. And the 6th station, it was blank, but I included logbook because a month earlier, when I went to Dr. NTI University in Andhra Pradesh, logbook was given 10 marks, so I included this. And you see, I'm examining my student. I'm seeing her logbook and the thesis, because thesis is to be seen only by the external examiner. So in this, I asked, what did you do for 3 years? The OP and surgical work. And they told me that first year they did this in surgery, second year this in surgery, third came up to doing the bits of surgery. And I also asked them for what are the presentations and what are the awards, if any. So this was all my idea. So and no one said no to it. So, so this is my recent experiences on 7th of February 2025, and at being the internal examiner and chairman at Shahdan Institute of Medical Sciences, Hyderabad. Me and the other examiner there, she's from SD Hospital. So the basis of this is my certificate from the revised basic course workshop, which I got for the medical education technology. And I was just seeing today's morning news that this basic course workshop in medical education technology is a must for all the teaching staff. And see that these are the OSCE stations. I separated them by a screen also. And a month earlier, when I went to, as the external examiner to Rangaraya Medical College, Kakinada, under Dr. NTI University at AAP, this is how I was given the thing. But OSCE, you see, the last column is 100 marks. I could not change it because this comes from university. So I kept it at 100 marks, and being the senior most, you can see the two internal examiners didn't say anything, and me, I just made it into 100 marks. So I just kept five stations. So 5 stations, 100 marks. I made it 20 marks each for each OSCE. And logbook, you see separately, is given the 10 marks. So it came in under my criteria. 10 marks is given, logbook is given there clearly. I can't change it. And as someone said, this is the new criteria. It was 400 for theory and 400 for Viva. And that is 300 for practicals and 100 for Viva. So it comes to 400 each. So you see, previously it was 300, now it's 400. And so this is PG exams. Now I'll talk about the UG exams in short, just which I, again, this comes under Undergraduate Medical Education Board of the NMC, and OSCE was first introduced for the 2023 batch. That was 2 years back. Batch admitted in 2019. And you see here in short and small in center, there is 5 stations in center. No, I can show it here. There are 5 stations in the center. It's given there. So 5 stations of 5 marks each, 25 marks, and duration is 30 minutes, along with 1 long case and 2 short cases. And again, I used my method of teaching, which no one said no. So I kept 5 OSCE stations, 5 questions, 1 mark each, 25 marks. So the 5 stations, as per the NMC, which I just picked up from the guidelines, were one was data interpretation. Data interpretation means we give the students just like a case. Like in COVID time, there were no cases, so we used to give charts, clinical symptoms and signs, and we asked them to give the data. So that was one station. Second station was charts, and again, if you go through the CBMA guidelines, these are the cases which should be kept for the undergraduates: allergic conjunctivitis and xerosis, corneal ulcers, glaucoma, anisocoria, subconjunctival hemorrhages. And the third was skills demonstrations. If you get a patient there, or instruments. So I kept instruments as IOP or furnace, and others we asked them to demonstrate skills of visual acuity, pupillary reactions, and ocular motility. And number 4 was prescription of glasses, because the lenses are removed. So I made this like this. I made a chart like this and asked them to tell me what refractive error and what are the lenses used. And number 5 is the counseling. The counseling. Again, I keep a chart station asking how do you counsel a patient, a child having myopia, and how do you counsel a cataract surgery patient going off for surgery having sugar and BP. So these are 5 stations, and as the previous speaker said, we have to see the attitude and we have to see the AdCom also. And this is there; it's a part of the recent things. And the last 2 slides. So here you see, this is the UG examinations in my 3 colleges, which I was the main examiner, with my other colleague being Dr. Sikandar being the other examiner. So I gave the individual examiner worksheet. And you see in 5, I'm talking OSCE only, the 5 OSCE stations, I asked the examiners to mark themselves, and then I compile it as a compilation master sheet. This is all under the NMC guidelines. So when I compile the OSCE station or anything, I take an average of all the marks of all the examiners. That is one method. Or if I divided the students, like if MBBS students are 25 per day, then I make it, I take a total of all the examiners. So either you take an average marks or you take a total and then divide it like this. And my last slide is the concluding remarks. The OSCE stations are, which covers more of the subject in a well-structured format. And it assesses the students' knowledge, competencies in all the 3 domains, that is psychomotor, affective, and cognitive, in an objective and unbiased way. And the training for the OSCE is to be given to students during their clinical postings. And in this, we have got 2 assessments: the formative assessment, which should be held regularly during internal examinations, and the summative assessment at the completion of the PG and UG program. And what we found out was it becomes more meaningful and more beneficial to the students. And if you see one of the students here, this girl here, after the exams in Kakinada, she came and sent a message to me saying that she topped the university. So in MS ophthalmology, that is the Andhra University, under Dr. N.T. Uchas. So that becomes beneficial for her also. And I took an assessment from all my examiners. They were very satisfied with this method of examinations.
Yeah.
Thank you all for
Thank
your
you, Professor
presence.
Rao. I think you implemented it for the first time in your institution, right? The scheme, this scheme of examination. For the first time you implemented.
Yes, I had a free hand being the senior most. I'm having about 33 years experience as a teacher.
Were there any kind of difficulties or any
No,
special
one. All
answers?
were very happy. All were. See, you can see all the examiners, photographs, the internals, externals. All said yes, it's the best method. In fact, a lot of them took my papers. They said we want to come. Not only ophthalm. They said even ENT, surgery, medicine. They said your format is very good.
Yeah. And what is the like feedback from the students? How do they feel?
Students,
about
I
this?
said, see, one of the students immediately she sent me that I topped the university.
No,
One
but the
girl.
process of examination, are they comfortable? Or
Yes, they're
do they have
comfortable. They're
any-
comfortable
any
because
problems?
they get a chance to get more marks also.
Yeah.
Because it's structured, it's divided. They get more marks.
Thank you.
Thank you. Thank you all. Thank you.
Very good presentation, Professor Rao. I just have a few questions for you. OSCE, yes, I mean, was started because our traditional, assessment methods were not uniform, they were
Yes.
not structured, and they were not transparent. There was a lot of bias,
Biased.
examiner
Exactly.
bias, patient bias,
Exactly.
But the beauty of OSCE lies in feedback. So have you included feedback as part of your OSCE stations? Actually, I started using OSCE in the year 2003, 2004.
Was
Yeah.
it
we-
permitted? Was it permitted that so many years back? OSCE?
No,
I
I
don't think.
started it as part of formative assessment.
Was all this there those years?
Yes, yes.
It was there.
Yes, it was there. In fact, that was my Jipmer Pondicherry project,
I'm from Bipal,
NTTC,
Pondicherry.
yeah, NTTC
Okay, that's it.
project.
Okay, that's it.
And then we continued it, and I mean, that college is still continuing this,
Okay.
but we started it as formative assessment.
Fine.
Because in summative assessment, there are so many limitations. And unless
Yes.
you have more of performance stations and which is clubbed with feedback,
Summative we are limited by the university.
yeah. Now, actually, with CBME, they have made it compulsory. But for postgraduate, for undergraduates, it's fine. For postgraduates, I personally feel that workplace-based assessment is better because OSCE is done in artificial setting.
Yes.
While workplace-based assessment is done in real-life situation, like in outpatient department or OT or emergencies or IPD,
That's why
where you are assessing their performance and not just competence.
Excuse me,
Thank
that's
you.
why
In
I.
OSCE, we are assessing only the competence.
I think
That's why I
we can
included.
discuss.
That's
So
why I
that
included
is-
logbook
yeah.
also. I included logbook.
I
It's a
think there
dynamic
are
logbook. We should
many
know
things
what
to
they're
be
doing.
discussed
True.
Thank you,
over
madam.
this.
Yeah.
Thank you all.
Thank
But we have a constraint of time, so please, I think we'll have to do it faster.
Okay. Next speaker is Professor Gurstinder Singh, and Professor Samantha will introduce him.
I think that
Professor
Gursinder.
Sundar Singh is known to all of you. He was the eminent professor and head of the Department of Government Medical College, Patiala, for many years. He was one of the pioneers in North Zone Ophthalmic Society and a great teacher in northern India. After his superannuation, he joined Adesh Medical College near Haryana, Punjab border. We are very much happy to have Professor Gurstinder Singh as one of the leaders of Forum of Ophthalmic Teachers of India.
Thank you, Dada, and my dear
Gursinder,
colleagues and friends.
5 minutes.
Yeah, sure.
Yeah, do it fast. Thank you.
I think I don't have too many comments to make. Actually, I'm making some personal comments or observations on whatever transpired at 48th National Assembly in Chandigarh. There was some recommendations. Some repetition might be there. So one of the aspects that was brought up in the first talk by Dr. Tyal was that orientation, it has to be 3 to 6 months. And in this, you make the student orientate with the department and teach the basic skills, and including and basic skills have to be taught by the good senior faculty. Actually, I think the basic skills are most important. So what happens is we leave it to the junior faculty, and then you learn the application basic skills, hands-on training in dry and wet lab, And of course, we know now the importance of dry and wet labs before we go in for surgical exposure in OT. And then of course the research and academics at the next stage, and then of course summative and formative assessment are a part of PG courses. Now, what is the, how do we standardize the teaching methods? You know, there is a need for uniform teaching method. They are not uniform all over India. Each institution has its own teaching method. And integration of practical skills with theoretical learning should be the most important objective, you know. And the use of simulation-based teaching learning method in dry lab and wet lab are essential for skill training. And a lot of institutions, they still don't have wet labs for this kind of training, which is in fact desirable. Then implementation of structured clinical training program is another aspect of it. And use of digital tools, AI-driven teaching and learning is also very important. AI can help you in a way, it can be a bane or it can be used, so you have to use it in a positive way. And simulation-based teaching modules and case-based discussions for better clinical understanding. So instead of the emphasis on the theoretical aspect, you should have more emphasis on the practical aspects, you know. And the only what I've seen in over the years is that when you ask the students to prepare for seminars, so they come up with the rehashed seminars from the net, it's culled from the net, and of course then at the end of the day what you find is whatever they are trying to tell you is all from the net, you know. So I think the flip technique, you know, where you just ask the students to prepare the seminar in advance or distribute the seminar in advance to all the PGs, and the next day you have a discussion on that rather than presentation, and you ask the questions. I think that's a better modality of PG training. That's my experience. So I normally try to give them seminar a day ahead. It's distributed to all the PGs, whatever seminar is there. Then of course we discuss it in the seminar. So it's more of a question answer session, maybe moderated by even the students or PG students themselves. And of course problem solving and critical thinking. And these are different teaching methods: lectures, case-based learning, simulation, interactive sessions. And this is, I think, their relative importance. I think the lectures are, I think, the least important part of our clinical training, you know. Case-based learning, simulation, and interactive sessions, they are more important, and they should find a higher, and they should come higher in the hierarchy of, you know, different methods. Then another thing is curriculum development again. This is an exercise which has been ongoing with the NMC, and state standardization is not there, and especially PG curriculum, you know, still the competences have not been specified, you know. So I think UG curriculum is quite, they have, you know, sort of come to some what is to be done, what are core competences, but as far as PG is concerned, it has to be outlined, and each institution has to have their own, you know, observation on it. And of course, emerging technologies, they have to be involved in the teaching, you know, like use of AI and use of teleophthalmology and use of artificial intelligence. And then, of course, competency-based assessment tools development, objective structure training, OSCEs, as previous speaker has emphasized this. But the only thing is that OSCEs are not standardized as far as in a college. Somewhere I go and there are 10 OSCEs, somewhere there are 5 OSCEs. I think last time it was suggested you have 5 OSCEs of 5 numbers each. So all these have to be, you know, standardized. There is no standardization in this as far as OSCEs is concerned. And then of course assessment evaluation strategies. These are different: formative, summative, self-assessment, and peer reviewed. And I think the formative strategy assessment is more important than the summative, because it's, I think, more ongoing process. And self-assessment is another tool. And then of course faculty development is another aspect which we have to look into, and has teaching and mentorship skills. So I think senior teachers have to mentor the junior teachers also. The mentorship of the teacher itself is very important, because junior teachers are more inclined to do the clinical work as compared to the senior teachers, and they are not too much into teaching. And other aspect is that senior teachers should take the onus of teaching the UGs also as well as PGs. And so this is, in fact, you know, this faculty development would entail research training, online courses, mentorship, workshops, and of course research initiatives are required, and then of course integration of ethics and communication skills. Thank you very much.
Thank you, Dr. Gursatin. I think we'll go to the next topic. Next speaker, please.
Now I invite Professor Ashok Nanda sir, and Professor Samanta will introduce him.
He is coming from Bhubaneswar, Odisha. Right now, he is the head of the Department of Ophthalmology of High Tech Medical College, Bhubaneswar, Odisha. He is a great leader in our Forum of Opthal Teachers of India. And we are all looking forward to have our next meeting, the 9th National Assembly of Forum of Opthal Teachers of India in Bhubaneswar on 10th and 11th of January 2026 under his great captaincy. Professor Ashok Nanda, sir.
Thank you, sir. Since no specific topic was given and a broader discussion was to be done on this, my slides were basically common to what other my previous speakers have said. With the NMC guidelines are basically aimed to standardize ophthalmic teaching, to have a uniform teaching method, to create competent ophthalmic surgeons with appropriate expertise, and have specialists who not only can provide high quality healthcare and advance healthcare to the patients, but also improve the science through research and training. So with this objective, these NMC guidelines are set. I am not going to go into the details of this because of shortage of time. But when I was sitting here and I was thinking that since this is a closed group of faculties who are in medical colleges, I jotted down few points which came to my mind to sort of improve the quality of teaching, and I would be like discussing that instead of going through my regular slides. So before I actually let me just put up 5-7 points which I thought should be discussed. One is, we all know that the number of medical colleges are increasing in leaps and bounds. Every district is supposed to have a medical college. That's what the objective of the government is. So in that context, the quality of teaching, I would not say the quality of teachers, but the teaching quality probably is suffering. So the most important point that comes to my mind is to make the teachers know what should be taught so that their skills of teaching can improve. That's the first thing. So the workshops for teachers is essential to standardize the teaching format. The second point is the focus on medical ethics and medical legal aspects have to increase, because henceforth people do not see doctors as a noble profession. They see them as service providers for which they are paying. So naturally, the chances of landing up into medical legal aspects are increasing if you do not follow the ethics properly. So that focus has to be there. As teachers, it is our responsibility. We have to improve on the communication skills, and in that context, I think the best way is to have local practitioners who have excelled in their practice to give their idea to the students. They can become invited faculties so that they not only teach the students about how to excel in practice, also how to improve their skills so that they retain patients. So that way they can escape from the medical legal clutches. The fourth point I wanted to discuss is about PG thesis. Most of the medical colleges, PG thesis is just a plus minus on previous thesis. So we have to have a think tank and decide, because a student is going to stay with us for 3 years. So a definitive good quality research work helps both the PG students and the community as a whole. So this is definitely going to need some extra think tank, this thing. And mentorship, every faculty should be given a responsibility of a mentorship of a student. That is very important. The student grows, the growth is supervised. The students' participation in conferences, in state, in different forums, is the responsibility of the faculty. Surgical exposure, I must say, is very poor to almost all PG students. They maximum do some assistance to the main surgeon. Independent practice of surgeries are limited to few main centers. That is something which has to be there. Group discussion should be a part of summative assessment. Summative assessment, I do not feel is only your clinical skill, it is how your assesstive skills are, how you communicate with the patients, how you communicate amongst yourself, how is your participation into different activities in the medical colleges. These are all should be a part of your soft skills development program. And lastly, to improve the clinical skills, we must all, as a faculty, make sure that it is regular, not on a periodic basis that we normally do every 6 months or every 1 year. It should be regular, monthly examination in some form with feedbacks is essential. Thank you.
Thank you, finishing in time.
Yeah, I just wanted to say something. So firstly, I really appreciate the way you've handled the talk and, you know, give the key points. And here we have all teachers among us. But I just have a little, you know, query, because generally, why are we saying that the teaching is poor and we have to improve the quality? Has anybody
No,
complained,
it's not about.
or why are we saying it's poor? Because we're all, and all the people who are ophthalmologists in AIOS today, all of them have been taught by the same system. So what is making us feel that the quality is poor and we have to improve it?
Because it's not standardized, number one, ma'am.
But why? Where are we getting that? Has anybody complained? Has anything? I'm just asking, because I find in many of the talks we are constantly saying we have to teach the teachers this, we have to teach them that. Now why are we burdening the teachers by making them feel disheartened, dejected, that you're poor, we have to improve you? We need to rethink.
No. It's what you are saying is correct, because you are in a prime institute. You would not be exposed to newer medical colleges. So
I don't think like that. I think every institute, the teacher is doing the fact that they're dedicated and they're joining the teaching profession. I'm not criticizing you yourself. I'm just saying that I found many talks are like that, and we all tend to say that. So we need to. I think that they're in the institute.
no, ma'am. Actually, if you go through,
if you data that there is any poor quality anywhere.
no, the reason why I said this is because I have internal examiner and external examiner to some colleges, and I know the standard of postgraduates, how they answer and how they perform.
Thank you. I think
so. This is probably because our teaching
so
standards are poor.
Yeah, we get the point here.
I think Professor Ashok Nanda is right in some way, because keeping in view the uniformity, because institute AIMS is different, PGI is different, and several of the medical colleges may have excellent teacher, but there is a question of uniformity in the teaching that varies. And very rightly he said about one, that surgical teaching is very less. Surgery our student get at some places, and there is a variation, but we at PGI and AIMS, we may find that excellent teacher, but Dr. Nanda, because we see the whole picture, then we will realize it. Na?
Thank you, sir. I think we have only five minutes to go.
Yes.
So now I invite Professor Ramesh C. Gupta sir, and Professor Samantha will introduce him.
You all know Professor Ramesh Gupta, the gem of Uttar Pradesh. Professor Ramesh Gupta was heading the Department of Ophthalmology in many medical colleges in Uttar Pradesh. Right now he is the principal as well as head of the Department of Ophthalmology of Government Medical College Meerut. He was the first president of Uttar Pradesh State Ophthalmological Society, and as well as sometimes he worked as the Director of Medical Education of Department of Health and Welfare, Uttar Pradesh government. Welcome, Professor Ramesh Gupta.
Thank you, Dr. Samantha, for organizing this particular meeting. And I think it's very, very important, because most of our previous speaker have almost covered everything in the UG and PG teaching in ophthalmology. So I wanted to give a broader aspect of medical education, not only concerning to ophthalmology, but in general. As we all know that it's a foundation of healthcare of any country. And of course, the quality of training motivated medical teachers, as we were discussing now, are, of course, is of the matter of concern. Therefore, it is very pertinent to attract and retain the best possible and motivated manpower for the training to produce the best. The trend recently we have seen actually, because since we all are teachers and we are from 35 years in the field, and we are seeing that the trend of best students and scholars drastically reduced in number for opting the medical career. And continuously we are seeing that the standard is going down. And of course, as per observation and work experience, at present usually three categories of students are pursuing the MBBS courses. That is, the wards of the hospital are nursing home owners, the ward of rich business people and non-medical government servants, and actually motivated pursuing medical medicine is very, very less. Especially, I'm telling not for the premier institute, I'm telling for the common medical colleges. And the possible and evidence of this effect of the current challenges, that is standard medical students getting inferior, because as madam was pointing out, that every time we are comparing from our time also and to this time also, and I think it is subsequent every year it's going down. The discipline, sincerity, diligence is also a matter of concern. The motivation for selfless service is reduced drastically, and of course behavior. And because of that, the causes above, the behavior and soft communication has changed a lot. Then, due to effect, there is a continuous year-by-year deterioration of the standards of passing out doctors, doctor-patient relationship, communication with the patients and the relatives, patient satisfaction level, and comparison of incomparable facilities in terms of infrastructure, manpower, expenditure on disease management, resulting in violence against medical professionals, and of course, medical establishment and setting up a vicious cycle. Then the problems of medical education in this country is that if we see critically, with the competitive examination, first you prepare for the MBBS, then prepare for MDMS, then you prepare for MCH, and if you see all the totality, it takes about 13 to 15 years for a common person to pass out the MS examination, MSMD, and of course 80 to 20 years for MCH and DM, if we consider the bond in most of the places in the country right now. So because of this, actually the people, good scholars, they are not opting for the medical career. So so this is to be seen in the light of comparison with the other similar or equivalent or comparable careers in the other fields. So that is also a matter of concern. So obviously there is a huge difference in both valuables and disadvantages of numerous legal hassles, much lesser opportunities to work worldwide because of practicing license issues, deteriorating social respect, lesser monetary gain in general, ambit of Consumer Protection Act, criminal negligence resulting to jail, financial penalty amounting in crores, nexus of non-social elements, and nasty patient attendance leading to many unwanted activities, and most importantly, violence and manhandling by the society. So these are the matter of concerns which we all must, as a teacher, we must concern and we should think about. Ultimate result of all these makes the whole profession unlucrative in general for a common student. So if you see how the thing we go, or we all know, so I am not going in detail, that what are the various options after the passing out after MS examination or MBBS examination. Everything, you've finished the course, you are at zero. And then you start that these are the various options, like a private practice, government jobs, the private hospitals or medical colleges, corporate hospitals. So these are having different their advantages and disadvantages for each one of us. We all know that. Then after this, in government establishment especially, the poor infrastructure, frequent transfers, inappropriate and irrational remuneration, administrative political interferences, poor work culture lead to compromised professional satisfaction, and frustrations make the job unlucrative. These conditions are little better in government medical colleges, but are not up to the desirable extent. Then presently government establishments, except for a few, are not having backup departments of supporting services like maintenance, biomedical, engineering, IT, fire, safety, electrical safety, security, claim, horticulture, etc., which leads to additional unwarranted workload on teaching faculty that reflects the quality of attitude, clinical work, teaching, training, and research. Because we are making in our government medical college our faculty as in charges of all these segments, which are not their jobs. And if something happens, they are held responsible, and the government takes action on them. Then fulfilling all these norms are must, but this results in loss of lot of time, money, and harassment for starting up of your own setup. So these are the various other things which we have to consider. Society's unrealistic expectations, we all know that what doctors should do. Then broad suggestions and tentative solutions by making the change in existing system. These are problems I have narrated. Now we are coming that how we can go about it. Then MSR, especially for teachers, must be revisited, because when we see that how these made by the NMC, the small group discussion, self-learning, lot of things are given, but the requirement is decreased. So that is the problem, that only motivated medical personnel to be recruited as teachers, because now it is a job, because people are joining as a job, not as a teacher. So that is another point which is important, which this is one of the answer to Dr. Radhika, which was listening on. Then stress on self-learning should be more. Non-core competencies may be taught to put under self-learning category. These are the various solutions. Then my thought is that we have to go for radical change in medical education, and that is that MSR, especially for teachers, must be revisited. It is too less to implement the curriculum effectively. Only motivated medical personnel to be recruited as teachers, methodology in our country we have to develop. Then stress on self-learning should be more, and non-core competency may be thought to be put under self-learning category. This is my suggestion, that because if we have to compare with the other disciplines, comparable should be comparable, so that good students should come in the medicine, that 2 years of basic medical knowledge, then 1 year of clinical posting or internship under strict supervision of designated faculty mentor. Then during 1 year of clinical posting, evaluation for the interest and best suitability of the candidate for the broad specialty, preclinical, paraclinical, or clinical, medical or surgical. Then 3 years rigorous training in the respective broad specialty. And then for super specialty, if somebody wants, then he can have additional 3 years by entrance examination. So what will this will give? The advantage of this radical change will be that the talent would be attracted due to comparative curriculum time period, as in the other field, approximately 6 years. Then unnecessary repetitions would automatically be avoided. Nation would get sufficient broad specialists in much lesser time. The frustration of not getting PG would be avoided. Also, now there is a practically very limited role or recognition of non-specialists in the society. So to fulfill the need of the general or family physicians, the required number of seats may be taken in the community medicine and family medicine. The significant monetary savings can be done, as only national stipend may be provided, the notional stipend may be provided during those 3 years of training for broad specialists instead of proper salary by junior doctors as per present thing. So thank you so much. Actually, I finished it very hurriedly. Thank you so much for this listening.
Sorry,
and I request that these advices or these suggestions should be communicated to an MC for thinking of these their concern to be implemented.
Thank you so much. I think we are at the end of the session. There's a moment to Dr. Swapan Kumar Samanta Appreciation Award from AIOS. I request Dr. Jagat Ram to please hand over. Dr. Suresh Ramarao, please. Dr. Suresh Ramarao. So there's a memento from the AIOS side, Appreciation Award. I request Professor Jagat to hand over that.
So now I will request Professor Chand Singh Dhul to say one sentence of wisdom.
Good morning, everybody. I think what has been discussed, I'll sum up that this is a old wine in a new bottle. All of us has passed through those stages, and everything used to be taught and examined and discussed. The only thing is that they have framed it in a structured way. That's what it is. What needs to be done for a PG is a skillful surgeon, and that's what is lacking in all the say areas. Now a PG passes out and he goes for fellowship to learn cataract surgery. That is the pity. So I will request all my colleagues that they must start a fellowship in the medical colleges rather than going for a fellowship in a private clinic or institution. Where they are working there, I should not use the word as a bonded labor. Means with less money and then doing the service there. So the surgical skills should be taught in the institution itself. When we passed out, we did independent 50, 60 surgeries. But now look at your PGs, how much skills they have earned. So theoretical, they will learn from chat, GPT or AI or whatever it is. Thank you.
Sir, look at the camera.